the exposure is smoking and outcome is myocardial infarction. And we want to investigate if there is link between this exposure of smoking and outcome of myocardial infarction. There are two possible ways I can do this association, risk and outcome association study. If I simply compare blood levels of cotinine, which is the byproduct of nicotine metabolism, I would have done a comparative cross-sectional study because I would just have noted that at one point in time, there was a difference in the levels of nicotine byproducts in the blood of those patients with MI and those patients without MI. But this kind of comparative cross-sectional study cannot tell me what came first. Did the patients who developed MI became so stressed that they started smoking? And because of that, there was a difference in their blood levels of nicotine byproducts? Or were they smokers? And that is why they developed myocardial infarction. So in a cross-sectional comparative study, it is impossible to tell which variable is the exposure and which variable is the outcome. Now, in contrast to that, when we do case control or cohort, we are following a timeline. We can tell what came first, that would be the exposure. And then what came after that would be the outcome. And we want to make smoking the exposure and myocardial infarction the outcome. So we, what we do is we, if we decide on case control, then in case control we divide our groups according to outcome. So we will have one group with myocardial infarction with the outcome and another group without myocardial infarction. And we will compare smoking history in both. And if there is a, how many chain smokers, for example, were there in the group with myocardial infarction and how many chain smokers were there in the group without myocardial infarction, we get proportions. We will compare these proportions using odds ratio and we will see what is the likelihood of a chain smoker getting MI. The other way we can do the same research project is by cohort studies. Cohort studies divide groups according to exposure or risk factor. So we will take one group of chain smokers and one group of non-smokers and we will follow them for the next 10 years. And at the end of 10 years, we will see how many chain smokers developed outcome of myocardial infarction and how many non-smokers developed outcome of myocardial infarction. We will use these proportions and apply the formulas for absolute risk reduction, relative risk, and we will know if smokers, chain smokers are at a higher risk of developing myocardial infarction. Now, so we have these two options, but the question is, what is a technical reason why I would either choose case control or cohort? Now, if you are, for example, instead of myocardial infarction, which is fairly common in our setups, unfortunately, if we were looking for an outcome which is very rare, even with the exposure, for example, we are looking for pulmonary fibrosis among smokers, and out of 100 or out of 1,000, only 2 or 3 are likely to develop that. As an example, I'm not sure of the statistics, I'm just giving an example. If the outcome is rare for that exposure, we can have a very large sample size and still not get our results. We can have a very large number of chain smokers recruited and still we still won't get the results because the outcome is very rare. In such a case, it is better to divide the groups according to outcome. So we go, because we have tertiary care centers and hospitals, and we can actually look for patients who have pulmonary fibrosis and those who do not have pulmonary fibrosis, and then look for the risk factor because smoking is fairly common. We are likely to find some smokers in those patients who have pulmonary fibrosis and those patients who do not have pulmonary fibrosis. So the conclusion is, if the outcome is rare, we go for case control study so we can target the outcome and divide the risk, patients according to outcome. On the other hand, if the risk factor is rare, for example, our risk factor is exposure to a very rare virus or a very rare pollutant, which is only found if a person visits a certain area. And that is, we are considering as a risk factor for, say, psoriasis.